Okay, how do palliative care methods in pediatric oncology differ from each other by age categories of patients?
Okay, so I'd like to start just by explaining, because sometimes when we talk about palliative care, we're not all talking about the same thing. So it's important that people understand what palliative care for children is. So palliative care should be available for all children with life-limiting or life-threatening conditions, regardless of their diagnosis, their location of care, and or their age, and should be implemented alongside active treatments. And very importantly, in children's palliative care, we use a multidisciplinary team approach, and we also make sure that we look after them in the location of their choice if we can. So children's palliative care is a special type of care, and it should be implemented for anybody who has life-limiting or life-threatening, so that's children with cancer. So as we know, many cancers can be treated and can be cured, but many can't, and so palliative care could be introduced for both, because we're not sure at the outset how many children will live and how many children will not survive from their condition. So if you implement palliative care early in the disease trajectory, then as at the time of diagnosis, then it can really improve patients and their families' quality of life and improve the way that their treatment is given. We help with the management of pain and troublesome symptoms. But palliative care is more. It's about the holistic care. So it's not just about physical symptoms. It's about looking after people's psychosocial, spiritual, and other issues as well, because we can't separate those in children or in their families. The trauma that families are going through, hearing their child has a life-threatening condition, means that it's something none of us want to face. So when we are faced with that, we want everyone to support us as well as our child, and we want the very best for our child. So incorporating palliative care early means that they're able to control symptoms, look after everybody, and perhaps involve the multidisciplinary team, which is important. I think sometimes there's confusion over what a multidisciplinary team is and what that looks like. But multidisciplinary teams include people from all different professions working together with the common aim of helping the patient and their family. So, for example, having a psychosocial support, such as a social worker or a psychologist, to help with perhaps dealing with siblings, how to tell people bad news, and those sort of issues is essential. So these are the softer sides of palliative care. The very hard side, and what you're asking me about, the differences in different ages, that for children, obviously, as they grow and age, their needs are different. From a psychosocial side, that's really important. So children who are babies obviously need different care. They need their activities of daily living met. Whereas when you're older and you're an adolescent, you maybe need to think about puberty, growing older, and what that means, and about your life, and you have much more awareness of what's going on. So obviously needs are very different. You shouldn't be mixing up the patients in one care location. So if you have a palliative care unit or a hospice, you should have age-specific facilities available for the children. You know, little 2- and 3-year-olds on little ride-around bikes are not what an adolescent wants, who wants a PlayStation or, you know, wants to be on social media. So we have to address people as individuals. I think it's important that when we look at the physical symptoms, children's palliative care is a relatively new specialty in many, many countries. So we're growing that base of evidence to support what works for symptom control and symptom management. And much of that has migrated from adult palliative care. But we know that in children, paediatric doses are different, and there's lots of differences in availability of drugs in different countries. So we have to be very mindful of that. Also of the culture. You know, do people want their children to have perhaps strong opioids for pain or dyspnea in a country where perhaps it's not socially or culturally acceptable? So we have to change mindsets and advocate for the development of palliative care. I think also we need to think about the different needs, so continuing education, making sure that people's lives are as normal as possible. Sibling support is such a huge need. If a child has cancer and they're coming for regular treatment, it often means one of the parents is away from the family for long periods of time. And actually trying to work how that's going to work in the family dynamic is a huge issue for parents. So that's very different. And of course, the thought that your child might die goes against almost nature, that we expect that we will all die before our children do. So to have to face that's a very difficult task, and being able to support the family in all of these psychosocial, spiritual and physical ways is really important. So palliative care is at a very early stage of development in Uzbekistan, and I've noticed that's huge enthusiasm, that people are really, really keen and really want to understand more about palliative care. So having been through many different countries, with this journey with many different countries, I can say that you have to start with achievable goals. Ultimately, what you really would love is a comprehensive palliative care service, multidisciplinary, integrated into your oncology services. So you have joint clinics with oncologists, so when children and their families are being seen, palliative care is involved from the outset. And if the child condition is improved and they run into survivorship, then palliative care doesn't have to be involved. But in many cases, in a country such as Uzbekistan, where perhaps there's a low income and some children don't get the treatment they need, then there's a higher incidence of childhood death in cancer, and therefore the need for palliative care is enormous. But they have this saying in English, you eat the elephant one bite at a time, and it is an elephant to develop the service, but it doesn't mean that you shouldn't do it. We have to start. So starting is joint clinics, specialist training and education. If we don't have healthcare professionals with the education and training to provide high quality palliative care, who understand pain and symptom management, who understand the holistic care we provide, then it's a very difficult thing to overcome. We need to educate nurses, doctors, social workers, psychologists, dietitians. It's a huge team that everybody works together to improve the life and care of the patients. I also think, though, that here in Uzbekistan, you've started on that road. You have palliative care, you're interested, you have teams in the hospital, you have beds, I understand, that are coming too. So this is really good for education and training of not just people who work in palliative care, but for people who are working in oncology who don't understand palliative care, because there's a good, easy way to transition between the two. I also think palliative care is cost effective. When you look at the evidence, there was a Lancet Commission document on the integration of palliative care into oncology in 2018. And in that document, it clearly sets out the benefits for patients, for costs, for futile treatments, for less diagnostics. So the economics is there. The evidence for pain and symptom management and quality of life improvement is there. So it makes so much sense to develop services. So once you've developed them in a hospital, you then have to think about a hospice and linking up so that you work together across services. And there is the Children's Hospice in Tashkent, and making those links is important. And then in many, many countries, children's palliative care is provided in the community, because obviously that's where most people want to be. They want to be at home with their family around them. But I understand culturally it's not really something for nurses to go into people's homes here in Uzbekistan. But I was also reliably informed that many people would have a nurse or a doctor in their family who would help to provide care. But it's more than just having someone to help to provide care. It's having that education and training, competence and ability to provide the medications people need to help with their symptoms. We don't want people at home if they aren't receiving good treatment and symptom management. And I think there's a lot we need to do over the next number of years to develop this. So, for example, improvements in legislation to ensure that people can get access to the drugs and the medications they need, which are on the essential medicines list from the WHO. So we have to look at how to develop these services and make it so there's almost specialist services, and then you want people to have an education, generalist education. And we should really include education on pain and symptom management and palliative care in the education of all undergraduate doctors and nurses, so that palliative care is not something that people don't understand.